We'll give her a chance to introduce herself before she gives the presentation. Welcome, Dr. Doyle. And she will be followed by Professor Wangai. Are we ready? Lydia? Okay, thank you.
So, good late morning, everyone.
Good late morning.
Okay, thank you. So, my name is Dr. Maureen Adoyo. I'm going to present a widely known topic, HIV/AIDS. I know it's been there for a very long time, and it has become a household name. And somebody is asking, with all that time, what new something are you going to tell us about HIV/AIDS? And for us, even it's worse because epidemics are coming and people are more scared of epidemics than the HIV/AIDS. But I can tell you for sure, looking at facts, HIV/AIDS is really something when it comes to our developmental agenda. Look at the budget in terms of HIV treatment and care and the number of youths that are affected. And so it is something that we need to continuously talk about. So my topic, all right. So the second slide. Okay, so that's something new I thought about. HIV/AIDS is about revolutionizing HIV treatment and care in terms of quality. And this time around, we are focusing on the patient other than the hospital factors. And like I've already said, it's now 4 decades since HIV/AIDS was discovered in Kenya. That was in early 80s. But I can tell you for sure it still remains a devastating condition. And if you look at the numbers, we have approximately 1.5 million new infections. And particularly so, this new infection falls between 2020 and 2021. And that goes with the landmark a period where we had COVID-19 epidemic. Of course, there was a shift of attention from any other disease and any other condition that existed, and everybody was looking on COVID-19. And naturally, services almost stopped looking at prevention and treatment, and so that naturally ignited the new infections. And if you look at global statistics, say 650,000 people deaths are reported globally. That means it's the almost second highest cause of death if you look at our global charter. And contrary to expectation, we are supposed to be seeing a decline in the cases of HIV/AIDS because there have been intensive intervention, and so that goes with the investments. So we are looking at global organization, we are looking at governments, even local government. There is some subsidies and budget that goes to HIV/AIDS treatment. And if you look at what we have now, it's really advanced treatment, and look at the tools that we are using even for data collection and also treatment itself. It's actually top-notch. So we are seeing intensive efforts in prevention, detection, and of course, treatment of opportunistic infection. And so if you look at previous years, there have of course been progressive achievements, but of late, since 2020, like I've already alluded to, the progress has been flattering. And of course, other than COVID-19, there is the perception that resources, more so from donor, is quickly shrinking. And overall, if you look at inequalities, we are going to look at youth trend, we are going to look at women trend, those who are socially affluent. We have disparity in terms of how they access HIV/AIDS services, treatment, and care. So again, on top of that, we have overlapping global crisis. So we have COVID-19, but if you look at global economy, there have been different things happening, including war that is greatly affecting on how people are currently investing in health. Next. So I want to bring to your attention areas where interventions have been. And the thing has been, we are looking at health sector as an institution, and we're also looking at health facilities. And so if you look at a normal hospital, a health center, a hospital maybe sub-county, and a referral hospital where we have service delivery, you will see comprehensive care centers. So under these comprehensive care centers, you'll have all the services that are required by HIV/AIDS clients. If you look at health workforce, we have training or capacity building for those who are just dedicated for HIV/AIDS services. And of course, they can sometimes provide overall services or general services in the outpatient department or even in the wards. If you look at information, it is well structured and mature when it comes to HIV/AIDS programming. We have, for example, National Health Information System. We have donors coming up with many systems just to gather information about HIV. It's one of those that have received intensive, of course, attention. And then that is now where a donor can also make decision whether they can still invest in HIV-related services. And rarely would you also see that we have shortages when it comes to HIV/AIDS drugs and also related medical products. So you can see the intensive investment that has gone to that. And of course, without saying, financing as well. All the programs that you are seeing locally or even internationally are geared towards HIV/AIDS. And if you look at leadership and governance, we have very organized structures, starting with UN/AIDS. In Kenya, we have NASCOP, National AIDS Control Unit, that is NAC. And if you look at public health institutions, public institution, including Rongo University, we also have a unit for AIDS control. And so you can see really organized structures, and you can see accompanying policies. So already that tells you a lot of investment has gone to place. But all these interventions were geared to improve access to healthcare services. If you're a HIV/AIDS client, it was meant to improve coverage, wide coverage, as opposed to when you used to walk long distance to go and get HIV/AIDS services. And of course, you'll abscond after going one trip and you have to spend so much amount of money in terms of transport. Then there was the element of quality, which has been partially tackled. And this study saw a gap and actually is trying to address the part of quality and patient safety. But in all this, we wanted to ensure that we have improved health outcomes. We wanted to see responsiveness in terms of turnaround time and waiting time, social protection, and everything that goes with that, including overall efficiency. The next slide highlights the challenges, and this time round, the challenge is actually the patient-centered. All right. So what am I saying here? After all those interventions that are targeting health facilities, they are targeting hospitals, they are targeting national structures, they might end up in vain because the focus should be on the patient. And so I'm trying to say here, if you focus on the patient, it is crucial in delivering high quality healthcare services. And the focus should actually be personalizing treatment. I'm sure you've gone to the hospital when it is a clinic day, and especially for children, you are all queued and jabs are put in a tray. and it is injected like that, like in a production room. And so that has brought a lot of issues. Why don't you specialize? Maybe the vaccination you have given me is something that I could react to. Or if I don't react to, then it is the jab itself that is not good. There are people you give a jab, and the following day their body is swollen. So why don't you stop the production kind of approach and target or focus on this one particular patient, and so the personalization of treatment. So this really goes a long way in showing a patient respect, showing them that you are responsive to their specific needs and also preferences. And so that goes also with the side effects that come with treatment. We all react differently. So if you are to focus on the patient, then we are likely to translate this treatment and care into some level of efficacy. The treatment outcomes are likely to be the one that is desired. And how do you measure that treatment efficacy? At program level, we have something we call 95, 95, 95 cascade, meaning that if I was to come into contact with you as a health worker, I should be able to have an opportunity to diagnose you. So if I diagnose you, what is the next step? I should put you into treatment. And if I put you into treatment, am I able to see positive outcomes? So in terms of viral load. So we call identification. You are put on treatment, and then the treatment outcome, which is viral load, is suppressed. So that is at program level. At a patient level, that is individual level, we want to see reduced number of times you visit the hospital because you are not sick. I mean, the number of times you visit the hospital is reduced. So if you are not coming to the hospital frequently because you have taken treatment, then we are happy to see that. And then mortalities related to HIV services should naturally go down. So patient-centered approach. We want one that is respectful in some manner, and we are calling for us to look at human rights. Give me my rights as a patient. How you are treating me, the norms bit of it, should be one that is acceptable to me. And that principle, of course, goes with acceptability and social environment of the patient. And so we are calling it a point of care, which is responding to human rights. And this is the experience mostly at health facilities and also hospitals. So if you look at health systems generally, looking at the national to the lowest level, which is the community, we are seeing variations in terms of how services are packaged. And particularly so if you look at low and middle income countries, there are so many missed opportunities, simply because there's lack of proper diagnosis, there's the element of treatment which is not of quality, and because people are not detected at early stages and treatment is not taking place, then we are seeing persistently high numbers of new infection. If we're able to put our house in order in terms of HIV/AIDS diagnosis and treatment, we'll not be having new infection as what we are witnessing now. And this is actually attributed to non-functional health policy. Somebody has always said that Kenya is one of those countries that is good generally in developing policy documents. But turning them into practical action is another story. And so many countries have really adopted a lot of our policies, including Rwanda, which is doing very well, and it's working for them. But we remain in the same spot in terms of health system challenges. And then if you look at context as to why we are seeing variation in terms of how services are packaged, our social culture. You know, in Kenya we have 45 tribes, or is it 43? 43, 45, thereabouts. Each of these tribes has got roots we define as cultures and social beliefs. And so how they even seek for these health services will vary. And it also affects the uptake of these particular services. And then we also have limitations at institutional level. We have dispensary, we have health centers, and of course hospitals at the higher level. And if you look at the way they are structured, there are some limitation in terms of resources. And particularly so, a dispensary you will see in rural area and a dispensary you see in urban area is completely different in terms of even resourcing and the infrastructures that are there. And so if you look at that element, people are not properly diagnosed and treatment is not the right one, and that has increased our burden of disease. And of course that goes with complications. But if you look at, again, developed world, it's working differently. They have achieved their own milestones, and quality of services is not an issue. And so highlighting these existing challenges brings out the need for us in terms of what we have in Kenya to understand the health services, contextual realities, and the functions down at facility level, and of course, we as patients down there, what is our expectation, or those who are receiving HIV/AIDS related services, what are our expectations? If you're able to deliver that, then we expect to ensure quality is actually delivered. So we need to change how things are done, and I'm talking about theory of change. And at the center of it, we have the patient. All the interventions that we are doing, whatever investment that we are doing, it should have the patient at the center. That's how we are shifting things. Instead of looking at health infrastructure just in its own, instead of looking at health team on their own, we want you to focus on the patient. So if you are training frontline health workers, the question is, how are they responsive to patient needs? If you are looking at organizational infrastructure, you are resourcing for them. Is it one that will fit our context and respond to patient needs? We have had scenarios where there is technology dumping. X-ray technology is used somewhere else, and new invention comes, and they do not know what to do with theirs. They bring it to Kenya in form of donation. But in ideal situation, the machine is hard to use, sometimes non-functional at all. And if you need to service it, you need to call somebody from where that particular technology originated from. So next time we are resourcing for our infrastructure, hospital infrastructure, is it the one that is responding to our preferences and needs? That is the big question that we need to go with when you're thinking about theory of change. If you look at our regulatory environment, there are so many policies like we have discussed. But when we are developing this policy, are we asking ourselves, where will we get the resources from? Our implementation context, is it marrying to the policy that we have put in place? So for this particular study, to answer to those questions that I've already posed, we use a design we call correlational and exploratory research design in a concurrent way, taking them side by side. Why did we do that? Because we needed to look at back events, history, what has been. And then where we are at now, we conducted rapid analysis for us to understand the quality of services. We needed to examine where we have come from in terms of reforms, of course, considering individual needs and preferences. And also at the same time, when we are doing this particular study, we needed to redesign on the ground and test back the patient-centered health system. We wanted to explore the practices of healthcare team. What is in actual sense happening? We have heard where mothers go to health facilities to deliver, and instead of getting empathetic services, they are beaten in the process of delivering. So we explored the practices that there is when HIV/AIDS clients are receiving services. And of course, we wanted to understand the rules of engagement between a frontline worker and also a patient. And so we went ahead and collected qualitative and quantitative data. And of course, when you have this data, there was need of triangulation, getting data from different sources to just make sure there was credibility from one source to the other. And then, of course, we wanted to cover the areas of convergences and divergences. And with these patterns, we'll again emerge with themes that were new. And of course, there was the element of verification and validation, and we use Kaiser-Meyer or Klein, and also Ballet's tests. And when we look at study sites, of course, we have 47 countries, and limitation with resources, we narrowed down to 5. And of course, these 5 were chosen based on a criteria. So say, for example, Homa Bay was picked because of its prevalence ranking. It's one of the top 5 in terms of prevalence ranking. And then Mombasa was selected because it has the highest number of key population, MSM, men having sex with women, with men. And also there was the element of commercial sex a lot along Mombasa, so we picked Mombasa. And then Nairobi being a cosmopolitan county, and of course with development that we are experiencing in terms of even health infrastructure. And then Kajiado is one of those counties that is ranked as marginalized, and of course having a pastoral community with really strong ties when it comes to cultural issues. And then we also had Isiolo, which had unique economic activities. So you know it's a transport corridor all the way from the northern part of Kenya coming to Mombasa. So the sample size was obtained using Cochrane formula, and the children that were engaged in study indirectly were 469, and 668 adults receiving ART treatment. So I will not give all the results, I'll give you only highlights. And when we are digging into how services were received by ART clients, few hospitals, or most of them, I think 60%, had a client booking system, and they will make a follow-up at 60%. Some were the rudimentary form of booking system, and in some circumstances, they were not even available. So they just treated for today and hoped that the patient will come back on a date that it was given. Whether they needed to remember in a way, that wasn't clear. And then if you looked at operations and service availability, most hospitals had 5 clinic days at median, that is the average. Others had 4 times in a week. And in few circumstances, like community-based services were conducted once, and family planning for lower level hospital again was conducted once. Which means if you did not fit in one clinic day, you will have to wait for the following week, and you missed an opportunity for treatment. The other thing about quality, how patient felt about services being offered, we put them into 2 categories. Those who are just enrolled for ART, and those who those with a different adherence status. And overall, if you look at Nairobi, Mombasa, people thought that over time the services had improved, and of course that goes with infrastructure, major towns, urban centers. And of course, if you look at Isiolo, you see at 50%. They thought there had been improvement, yes, but it was really low at 50%. And then looking at adherence status, again, you look at trends. Mombasa and Nairobi are scoring very well. Improved over time because of receiving ART services was high. And then look at Isiolo, again, leading at low with 25%. And then now finding relationship between points of care, what I call POC attributes and quality of care. There was a long range, but of interest, we asked patients how convenient it was for them to check up or even do booking, how long they took when they came to receive services, and administrative procedures when you're also in the process of continuum of care. And there was some significance level with a coefficient of 0.11 and then positive significance of 0.774. And then conclusion, again, these are just highlights and lessons learned. When you look at planning and scheduling of operations, including routine maintenance, they are really crucial in terms of ensuring that no patient was interrupted when getting the services. However, if you look at disparities in terms of routine maintenance practices, half of the facilities were lacking definite schedule. So it was just a one-off. They wait for the machine to break down, and then they will call somebody to fix it, as opposed to 2 weeks maintenance or a monthly check-in of the infrastructure by somebody who is specialized. And then resulting in diagnostic treatment and availability because of those breakdowns that we experience. If you look at organizational practices and culture, they had impacts on availability of services. Say, for example, those who had one clinic. That kind of practice hindered people in accessing services. Organizational culture. You open at 5 and close by lunchtime, these clinics. What if I was coming from Shamba? I had to go to my Shamba first to make sure everything is okay before I come to the hospital. And I've just landed at the hospital at 1:30 p.m. I will not be able to get services because I'm outside working hours for these clinics. And so that impaired accessibility or availability of services. Then now, if you look at youth-friendly services, community-based services, and family planning, which are crucial. They are the least clinic days. And if you look at those clinic days, again, it goes with underutilization. Not so many people came for those services. And the possible explanation for that was stigma and lack of awareness. So if a dispensary does not have a service charter when they're offering youth-friendly services, of course, that goes with lack of awareness. Now, from this study and many other studies, we are seeing the future is with us. We are trying to go right to community level, where patients are met at their point of need, your household level. You are paired with community units, which in cases where it's not refill, you can be tagged to a facility, and if you have complications, you can move to a bigger hub. So we have a number of facilities, we call them spokes, that receive communication from the community units, how the patients are doing, and then they can relate to county referral hospital or any other if a patient is experiencing complications. Now, the next one, we've been able to map linkages to services. And from this information, you can see how we have saturated the ground with this intensive service that is highly personalized. I will come to your house, take your weight, take your sugar level, high blood pressure, but they are not doing refills. And by that, if you are okay, we leave you. If you are not okay, you are referred to the next level like you have seen. So we have PCN hubs, the bigger hospitals showing the red. So, and you'll see the pattern is along transport corridors and big centers. And then the PCN spokes, they are right at the village level and highly concentrated. And then, of course, we are seeing mini hubs coming up again. This is peri-urban, and that is also a peri-urban. And so if we are to go community unit way with the smart PCN, then we are also able to respond to patient needs and preferences. And of course, we maximize opportunities in terms of treatment and care for HIV/AIDS patients. And so I thought that is a right-based approach and also enhancing quality of care. So that's the end of my presentation, and thank you.
Thank you. Can we give her a two-factorial appreciation? Open wide. Dr. Bila spoiled it. Thank you. We'll have the next presentation before we come to questions and answers session. Professor Wagai will present, before we go to questions and answers. Okay, I'm informed that we will do the questions first before the next presenter. Any questions for Dr. Adoyo? We can take 3, then another 3. If there's no question, maybe, yes. There are 2.
Good. Dr. Ari, there was a diagram which in my own, I called it conceptual framework. And that conceptual framework, there were some policies. And with these policies, at some point you say that the policies are not working. But there were a lot of policies that has been put in place. Now, for us to make these policies work, what have you proposed, or how do we, or what is it that at the end we are not seeing the prevalent going down? It still continues, despite there's a lot of policies being put in place, a lot of infrastructure is going on. That is one of the questions. The other one is, when we physically go to the health facilities, we find some people there. These people, they are not Kenyan government employees. So how do you relate with these people? They are also doing the same thing, but in your household. How do you now differ with what they are doing, and how do we link up?
Thank you, Dr. Doyo. My question goes to patient. When you talk of offering services to a patient, then it brings singularization of services. And singularization of services implies complexity. Because here you want to give attention to every patient at any instance for a service. So it brings complexity, and probably you could elaborate how you'll handle that singularity in service provision. I don't know whether you will consider technological architectures that enable singularization, like service-oriented architectures, or what are you putting in place to handle this complexity that is going to come about by this? Thank you.
First one is maybe a comment. Thank you for the nice presentation. Looking at your last slide on linkage and facilities, I would recommend that you work with the ICT department to make it real time, so that all those dots are active, so that if you point on a dot, it gives a profile of the facility or the profile of the patient or whatever. As in an example that I have is it's called Radio Garden. It gives you a map of the world, and every dot is a radio station. So if you click that dot, it tunes that radio station from anywhere in the world. So that will improve on your thing. But I think it's a very good presentation. Thank you. Please respond to the questions.
Thank you, Prof. And thank you for the questions. I want to start by addressing Professor Otenga's concerns in regards to the diagram. For me, that wasn't a conceptual framework. I would rather call it a theoretical framework borrowed from the source I already quoted. And so when I'm talking about making the policies work, it's about contextualizing policy, scanning around the environment and knowing what we have in terms of resources and the specific needs of these patients, and then we move upward to have a policy that addresses those issues. Many a times, health issues have emerged from global declarations, people going to a conference and they say Abuja Declaration takes force to all member states that were represented here and they have signed the declaration. Say, for example, Abuja Declaration, which requires that we set 15% of our total budget towards health. But look at time immemorial, since independence, the best we have done is 8.8 of our budget going towards health, simply because it's a borrowed policy. But if we had policy emerging from lower local level to respond to our needs, other than the think tanks just sitting down, imagining the problems, and boom, they have very beautiful bound policy document. So it's high time we rethink our policy processes. You have also alluded to that most of these facilities you go to, the people you'll find at the CCC, the comprehensive care centers, are not government employees. Currently the policy is, if you are to be employed as a nurse or a clinical officer in the CCC, you must have been an employee of government, seconded. So when the project ends or funding ends, you have the knowledge, of course, the capacity build you, and you can transition back to government services. And so that has resulted to a lot of transmission of knowledge and acceptability. The issue we had about Cuban doctors being widely seen is another policy of universal health coverage. Cuban has done very well in terms of universal coverage. And so there were models that were supposed to be brought here in Kenya to see how they function. But they're not only on CCCs, they rotate in all departments in the hospital. The other question is about the community health services. They are government NGOs. Yes, but yes. And we have a partner coordination office at national level. We call it ICC. And before you make an entry into Kenyan health sector, you must have been authorized and sent to the ground. And the policy has now been, like I've already stated, you must be able to absorb somebody from the government. They second employees, and they transition back at the end of projects. And of course, a donor will want to have some publicity. As much as they are giving services using government employees, they want their badges there. And that doesn't mean they are not Kenya employees. It's just that the badge is all over. That is my understanding and my experience, having worked directly with the hospitals. Somebody also raised the question of singularization and causing some complexities in terms of managing patients. And yes, it is a complex, but now reaching down to the local person. So we are saying a community unit will accommodate certain number of households. So we go profile the houses and their health needs, and we offer services. These health units have got people called CHAS, community health assistants, who relay information to the nearest clinic. We are talking about sub-hub. or a spoke. And then a spoke will communicate to a higher level hospital where we have specialized doctors. And they also have some meetings, clinical management meetings, and I suppose they are weekly or even regularly twice in a week. I think Monday morning and maybe Fridays, just to single out the patient at the lowest level with a particular complex issue that needs to be discussed, clinical matters. We have this patient presenting with these signs and symptoms or this complexity. How do we manage? And then they draw a plan for that patient. But who follows somebody down at community level? So there is that linkage, there is telemedicine, and we are using electronic community health information system to relay also the information. And by the click of a button, you can get a profile of houses, community units, how many patients have been seen, and everything is all there. In regarding the maps, yes, we want to do better in terms of technology. By the way, that map was generating using GIS and mapped the way it is. The only thing that is missing is that we need to make it from static to what? Dynamic. So instead of just seeing it as a photo there, we need to have it moving, yes, interactive. You click, you get a profile of the hospital. And so, of course, we encourage collaboration and we'll be reaching out to make sure it is more interactive. And by a click of button, you can know which community unit you belong to, and we're supposed to see you in terms of the network itself, primary care network. Thank you.
Thank you very much. I can see in front of me there are certificates that are very colorful and beautiful, waiting for the closing ceremony. We invite Professor Wagai to present. Professor Wagai will give a brief introduction about himself, giving us his profile. Then it takes 15 minutes to present.
Good afternoon.
Good afternoon.
Yeah, I'm Professor Samuel Wagai. I'm a botanist by profession, but we had a lot of interest in microbiology. When I talk about botanist, I'm talking of somebody who is interested in plants. And I've had a lot of interest, especially in ethnobotany, that is dealing with medicinal plants and their uses. And that is from the year 2006. I've been engaged in public. And majorly it is a key, this is a real basic science. And with ethnobotany, you find that majorly we are interested in those particular plants that are of medicinal value. So from my presentation, I'm going to deal with some plants used by the Luo traditional healers of South Nyanza. And we find that from time immemorial, mankind has been in search of plants and other materials that could be used to take care of pains, deformities, and diseases. So you find that we have really been using plants and other animals. Like if you go to insects, we have homeopathy. We use insects in order to extract some particular medicine from them. When we come to botany, purely plants, we use, we call it ethnobotany. So you find that there has been advantage. These particular plants, they are in our surrounding. And when they are in our surrounding, it makes our work very easy. A good example is when COVID came. You find that some of us who are in the field of plants were very much advantaged. Were so much advantaged because when people were dying, we were not fearing, because we knew we had medicines around us. And for somebody like me, I was having a lot of advantage because there is a plant which I want to patent. This particular plant, it treats everything on earth, everything, except death, except death. So that is the advantage which we have. So majorly, like this particular research, I'm with Dr. Gisesa. He's not here with me today, but majorly what we are interested in is trying to make a survey, especially of the traditional plants used by the Luos, and we try to see how they use them. Because if you look at the literature, you find that some people have documented these particular plants, but they have not stated how those particular plants are used, the dosage which are given. So ours was purely to make a survey, collect these particular plants, ask the traditional healers, what do they do with these particular plants, how they use them. So each herbal remedy contains small amount of several active ingredients. If you look at a single plant, plants have got alkaloids. These are phytochemicals. They have alkaloids, they have flavonoids, they have glycosides. These are active ingredients or compounds which heal diseases. Some are antibacterial, some are antiviral, some are anti-parasites. So this is what we really wanted to document. Second slide. So in contrast to the local or traditional plants, you find that the conventional drugs, those are the prescription drugs, or the drugs from Western, from the West, you find that they contain powerful dose of single substance. But the traditional plants or medicinal plants, they may have various active principles. But the one that has been synthesized, you find they have a single but high dose of ingredients. And that's why you find that they create imbalance in the body chemistry and cause new problem necessitating further treatment. And in many parts of the world, you find that right now there is awakening of people now trying to use these particular plants, whereby you find the knowledge people have gained, it is generally passed from one generation to another generation. Even in the Western world, you find that now people really are interested in knowing much about these particular traditional plants. So since the year 2006, we have been interested in herbal plants. We have documented majority of them. And apart from that, we have made some publications which has really added a lot of knowledge in this particular science of ethnobotany. Continue. So you find that this particular region, you find that there is a lot of rainfall. We receive over 750 to 1,000 millimeter rainfall per annum. We have got 2 seasons, long rainy season with peak in April and short rains in October. And you find that this is generally conducive for growth of diverse and array of medicinal plants. Because we are dealing with the Luo community, the plants that are in the Luo community, you find that correctly the Luo, they call them Joluo, are patrilineal and very local people. What we mean by patrilineal is that they do pass information from one particular generation to another, from a father to a son. That has really added advantage in this particular field of ethnobotany, because you find that the knowledge that a father has, he has to pass it to the son. The son passes it to the younger one. So that is patrilineal. And then you find that they practice clan exogamy. The Luo people practice clan exogamy. What we mean by that, it is better to get these particular terms, because it helps when you go to the community. In order to get information, you must generally know which this particular group you are dealing with. Clan exogamy is a case whereby you find that the Luo, when they marry, they don't marry from the next area. They marry from very far. And what is the advantage of marrying a lady from very far? They come with the knowledge of these particular plants from far off. Then they come to this particular home. When a child is sick, this particular child can be treated with this particular local herbs. These particular local herbs may just have different names, but you find that the way they use them in where their home, where she comes from, she will bring a lot of knowledge with her. So that is what is known as clan exogamy. Health condition in these study areas is generally semi-poor, whereby you find that by Kenyan standard, research shows that there is prevalence of malnutrition, anemia, and infectious diseases. So when we have all those, and this particular community, we say that generally they are semi-poor. They are not so poor, but they are in between average. You find that there is a time when they will always get problem, especially financial problem, that they cannot go and buy medicine in the hospital. So you find that having knowledge of indigenous plants will help them to alleviate the problems which they have. The objectives was to carry out survey and identify medicinal plants in the study region, interview the local herbal healers and other players on the use and preparation of herbal remedies. Continue. That was another slide. Study area was South Nyanza. Low medicine and health. Recent ethnography from Western Kenya described Luo medical practice as pluralistic. What does it mean by pluralistic? This one shows that they move between multiple therapy sources, ranging from they go to district hospital, through private hospitals, they go to drug shops, and to local herbalists. You find the source where they can get help are so many. Therefore, you find that health conditions in this area, just continue another place, next slide. So you find that the methods which we used was local. It was we just used basic. We just did questionnaire, and we were asking the local herbalist how they were identifying the plants. The information from the ethnomedical practice gathered by the healers were then entered into questionnaires and field notebooks. The healers were quizzed about their knowledge on medicinal properties of plants, methods of preparation of the herb portion, and the toxic effect, if any, were documented. Then vernacular names of these particular plants were also documented and recorded in the field notebook. Plants that we collected were allotted collection number, and then the voucher specimens were pressed, treated in herbarium, and were deposited in laboratory in the department, in the physical and biological department. Continue. Results. 35 plant families commonly used by the Luo traditional healers were identified. Both scientific and vernacular names, portion of herbal parts used, and medicinal properties were given as below. Most of the plant remedies were used for abdominal illnesses and skin infections. So we have so many plants which we documented, and I will just give a few. Like aloe vera, which all of you know, it belongs to the family Aloeaceae, and you find that the vernacular name is Okaka. This plant is a powerful herb for stomach ulcers, skin wounds, headaches, and constipation. It is an appetizer, a laxative, a purgative, and provoke uterine contraction, increase the menstrual flow. That is according to the healers. The local healers, they told us what this particular plant does. And also we find that it treats burns and fungal infections. So with us, we could still go again to the literature, try to see, is this what they are saying is in concurrence with other workers who might have done the same work. We find that it improves also appearance of scars and skin. It is digestive and treat duodenal ulcers. And how do we administer these particular drugs? You find that 2 to 4 spoonfuls of aloe juice was dissolved in water. Fruit juice or milk are taken 3 times daily to enhance its effective during the treatment of skin and eczema. Medicinal properties, we find that it is laxative, which means it relaxes the stomach. It is stomatic, it is oxytoxic, anodyne, and emollient. You find that these particular terms, when we say that it is emollient, you find that this particular term means that it strengthens and gives a lot of strength to the stomach. When you are sick, you find that it helps the stomach now to remove a lot of gas. So aloe is generally very good for stomach problem. Then we have another family. We have got algues, only around 3 families. There is another family known as Anacardiaceae, and the species we are dealing with is Linnea stewforthii. Vernacular name is quogo. That is a plant known as quogo. It is a pleasant toxic for stomach ache. For you to use it, there is tip, or you pick a spoon, fill it, then you add a cup of boiling water for 30 minutes. You realize that the healers were telling us that there are some particular plant materials that you have to use cold water, some you have to use hot water. The reason why you do that is that when you use cold water, there are some of the ingredients that will not get distorted. But there are some which you use hot or warm water, it will now dissolve easily to the solution. So that's why you use different types of temperatures when you are dealing with this particular plant. And then also something which we notice is that in the type of administering this particular medicine, you realize that the healers were informing us that when you are sipping any particular medicine, in the Luos community, we have around 10 methods of taking this particular medicine. Especially when we talk, they were saying that when you drink a concoction, a gentle drink of a concoction, you'll find that there are some medicine that you just take, you sip gently. And then that is called mado. And then there is another type of concoction which you take, but you drink it in haste. You just drink it in haste. They were calling it royo. Then there is another whereby you are drinking continuously. Some medicine that you have to drink continuously for it to work. That one, what they were saying that it is quarter. Then there is another medicine that you just have to lick. You only lick. They were saying that one you nango. So you find that it has got a very rich way of doing things. Then there was also another whereby you just test. They were saying that that is belo. And then there is another way of using this traditional medicine. There is a way whereby you just suck. You suck it. They were saying that one is nyodo. So there was so many ways of taking medicines in this particular community. And then there is another way whereby you use something known as a straw. they call it oseke. They were saying that that one medicine now you do sipo, you sip. And then there is also another way whereby the medicine, you don't actually lick it, but you just test very fast. They call it loeco. Just take it very fast. So you find that there was an array of methods of how these particular medicines were being taken in this particular region. And then from Anakadesi, go to another family, which was very important for us. Yeah, there is this Brassica oleracea. Vernacular name is cabbage marachar. This is the normal white cabbage. The normal white cabbage, it is medicinal. It has been found to be excellent in gastroduodenal ulcers, excellent in diabetes, intestinal worms, wounds, topic ulcers, eczema, and acne. Then you find that for gastroduodenal ulcers, a cup of freshly prepared juice is drunk 3 times or 4 times daily before each meal on an empty stomach. So those are methods which they were which is being used. And then apart from that, medicinal property of this particular cabbage or the cabbage, you find that it's a vermifuge, which means it is it controls worms in the stomach. It is anodyne because it relieves pain. It is styptic because in that way you find that it arrests hemorrhage and bleeding. So that is what they told us that particular plant does. And then we come to another family known as Labieti, Ajuga remota. Ajuga remota, this is a plant that we have really worked on. Ajuga remota. In the Luo, it is called Nyanyodi. I wish I had the picture of this particular plant. This particular plant, they say that it's an excellent and a powerful herb for constipation, diarrhea, and malaria. And how do we take it? 3 cups of a decoction made from 10 grams of leaves and stem is drunk 2 times a day. Generally used for children. It is anti-diarrhea. It is anti-malarial. Which means if you look at medical properties of this particular plant, it is stomachic. When it is stomachic, which means it relieves any problems of the stomach. And apart from that, you find that it is laxative, promote bowel action. And then apart from that, it is tonic. When it is tonic, that one, it means that it invigorates and strengthens the stomach. This particular plant, this is not part of the research, but we documented this particular plant with Professor Lauren Manguro and Professor Lemen. You find that this particular plant, why I bring this is because when we were doing the research of trying to investigate those particular plants are medicinal in the Luo, you find that the ultimate end of everything is for us to try to see the active principles in this particular plant. So in this work alone, it was only investigating. It was only collecting. Information of the traditional or medicinal plants in this particular community. But ultimately, what we end up with is now trying to get the real active principle, phytochemical studies. So we did a phytochemical studies of the Ajuga remota. Kariuki also did it in the year 2002. And with that, Kariuki got around 6 active principles. With us, we got 2 very important principles. Those are glycosides and flavonoids. Flavonoid and iridioid glycoside of Ajuga remota, we found that particular compound from the aerial parts of this particular plant. So whatever we've done in this particular work, our next step now is to go and look for active principles like we did in the year 2006. So in this particular research, purely it was only to document. But after this, now we go deep into looking at those particular active principles in each and every plant. We had 35 plants that we identified, and that is not enough. We have so many. So this is the compounds that we generally got from a agar remota. It's a complex thing. They are the active principles. So in this particular basic science that we do, we just collect information now from the local doctors, healers. And so after we've gotten the information, they tell us this one is for treating this and this for treating this. Now we go back into the laboratory, do the phytochemical studies. After carrying out the phytochemical studies, you get the real complex compound that treats that particular disease. So that is when now you ascertain that this particular claim of the healers is really correct. Somebody may say that this particular plant has got some effect, but you look at the phytochemicals, which is it belongs to families or it belongs to group which is not even antimicrobial. So discussion, just go another. So in conclusion, Luo healers use different plant species from the to treat the same disease condition. So you find that a family may be used to treat different diseases just because might be another species has got other phytochemicals that the other one does not have, or they augment themselves. That's why you find that sometimes you are given not only a single plant, but you may be given a mixture of plants. But scientifically, is that if you go and investigate why you are given two plants, then you realize this particular two plants, maybe one is having another active principle that augment the other active principle of that particular plant. That's why you are given two to take. The Luo community possesses an extensive knowledge of the medicinal properties of their flora. Most Luos are increasingly shifting to the use of plant medicines, which could be attributed to the fact that Western medicines are becoming comparatively expensive. Medicinal herbs are preferred by the Luo community because of their familiarity with them, according to traditions and past experiences. Also, these plants are easily available in their surroundings. And then, economic hardship, especially in the rural setup, render the herbal medicine an alternative for survival. Another slide, recommendation. Further studies on the Luo traditional way of using medicinal herbs should be carried on to another higher level, whereby we are saying that from here now, we have documented. It is up to us now to go further and to go and take a pharmacological laboratory studies, assess the efficacy of these particular plants. Pharmacological laboratory studies assessing the efficacy of this plant needs to be taken seriously. And then apart from that, we find that there is overexploitation of these particular plants, because if each healer is harvesting these particular plants, then exploitation of this valuable medicinal plant needs to be regulated. Apart from that, ex situ and in situ conservation strategies to be embraced by the stakeholders. When we talk about in situ conservation, is that we pick these particular plants, we bring them to our surrounding, we propagate them, then we multiply them and make sure that they are not extinct. When we talk of ex situ conservation, here is a case whereby we go to where these particular plants are. We make sure that either we protect them or we allow natural regeneration to occur so that they increase and we protect them from where they are. Then another recommendation is that Rongo University to set up a botanic garden. There is need of Rongo University to set up a botanic garden. The reason being that sometimes we have seen students or pupils coming to visit Rongo University. And what do they come to see? They always come to see buildings. But if at all we had a botanic garden, which has got medicinal plants, then you find that apart from that, we can get from such type of ventures. Apart from that, it will be a center for educating our young ones on the way to conserve plants. Then apart from that, it is good because if you look at ecotourism, we can promote ecotourism by having a good botanic garden. You'd go to museums of Kenya, they have got a good botanic garden, and you find that with us here at Rongo, we have got a very, very good climate, which means botanic garden can be actually be established. Thank you.
Thank you, Professor Wagai, for the enlightening presentation. We will take questions. We take the first 3, then he responds, and then we take another 3. 1, 2, 3. In that order, then 1, 2, and 3. Karibu. Prof, here first. Take this.
To appreciate the presentation of that paper on issues traditional medicine. I happen to have worked under a very serious traditional professor of medicine, Professor Adam Chepkwony. And from that herbal issue, a big project came, which was funded by the Templeton Foundation, US. And it was a big collaboration with Nigeria. But the problem that they were trying to tackle, I was among those, because they were trying to see where people come from if such things were taking place. There was a big debate on the issue of transmitting knowledge from this herbal medicine, and in most societies it was patrilineal. But in some societies in the West it was matrilineal. And when they were doing the comparatives, they found that the matrilineal transmission of knowledge was more effective for reasons that we are yet to know. But another problem which was big, dosage. I've listened to Professor talk about those plants in the rural community where there are several formats of taking. You can scoop with a spoon without even saying which spoon. You can lick. You can take very fast, you can take very slowly, you can take continuously. The real problem with African traditional medicine is the quantification of the dosage. Because in China, I know, and I've experienced, I've seen somebody who have gone there from Moi University, that is the what is this, wing of the hospital, and the traditional. And the traditional is as accepted as the Western, and people prefer the traditional because of there is no side effect. But because they have reached that level of scientific proving of quantification of the dosage. So I think for me, I'll recommend to Professor Wagai, who is in a very good area, so that you can address the issue of dosage and why does this knowledge in Africa not solved most of the problems that we experience. We hear there is a cholera in Kisii or in other places, and this traditional medicine men and the knowledge is there. Until Western medicine intervenes, we die, all of us. something you have to think about. Dosage is a problem. Either overdose or underdose, which is no longer effective.
Thank you very much, Professor Wagai, for that presentation on indigenous medicine. I want to link my question to what has been already said on dosage and quantification of these plants. Ideally, we know plants vary in terms of phytochemicals with season. There is times of the year when the concentrates are very high, and there are times that the concentrates are also very low. And again, it depends with where it is grown in terms of environment, and so that goes with the concentrate. And so my question is, how did you arrive at the dosage, teaspoonful, that you can lick, you can fuse, or you can quarter? So that element of quantification still remains a challenge for me, how it was arrived at.
Thank you. I have 3 questions for Professor, because he was bringing us the Luo herbs. Prof, are you, which one in the Luo are you? Because in the Luo doctors, we have a number of them. You're just talking of a doctor. There is Jajuok, Janawi, Jasutro, Jatiet. So, you know, to get there, you must be in specially, just like as a professor, you are a professor of special. So in this medicine, you are on which side? Jasutro, Janawi, or which one? 2, just to help you, if you look at these guys, they have, that quantification is there. The real medicinal man will tell you how to scoop it. If it is this one which is not burnt, but the one which is burnt, you remember, they will always tell you, you take it. A lot of keenness because of the fear that professor of Western education will snatch them their knowledge. So they are there. But I would wanted you to help me understand this terminology of the Luo medicinal man or the Luo healer. You call them traditional healers. So which one is which one? What do they do as healers? You know, the healer is there, the traditional healer. But then they are specialized as like a professor, sociology, philosophy, business. Thank you.
Yeah, I think I've been asked to say what I am. Yeah, there is 3 groups here. There is Jathieth, there is Jajuok, and Janawi, and Jasutro. So I want to explain maybe to those who don't know this. When we talk of Jathieth, that is just a normal healer, somebody who heals. He is having medicinal plants and he can heal. And then there is somebody who is Jajuok. Jajuok is a nitrine runner. This is somebody who uses juju. He's a night runner. With him, actually the Jajuok, we have got 2 types of juok. This is a person who can come to your home and scares you. And they use some spirits which are very evil. They can scare you that you can even not wake up in bed, but it's just by the door. Their powers, those are people who have, those are bad group of people. Then we have Janawi. Janawi is somebody who he can look at you. He can just look at you and you become sick by looking. Those are also having evil spirits. But Jathieth, where I belong to, we can heal you using this plant because we have now known their active principles. So I am a Jathieth. But apart from that, Professor asked a very good question about the dosage. The dosage certification of dosage, you find that in the traditional way of healing, there is plants which have been used from time immemorial. They have been used, and that particular knowledge is being passed from son to child to grandchild. So, and we don't add anything more to it or delete. You make sure the way it is prescribed. If it is a matter of quarter, you just take very, very fast. You take it like that. You don't miss, you don't leak it. And if it is about leaking, you just you don't do any other thing. But generally, that is why it takes case of the dosage, because if at all this particular medicine you just have to leak, which means you take little quantity of that particular active principle. But if you take more than that, you drink it, you may overdose. But in traditional medicine, nearly there is no overdose because these are vegetables. Majorly they are, like now cabbage. I've shown you the cabbage. Can you eat cabbage until it hurts you? Nearly none. That's why the dosage of that's why as scientists now we are coming with formulations. Like this particular plant, Ajuga remota, which in the year 2006, we took it and took the samples to Germany, and they gave us the active principle. Then we go to the literature and try these flavonoid glycosides. How does it behave with antimicrobials? How does it behave with bacteria? How does it behave with a virus? So you find that with knowledge now, you can do something good. Right now, we are in a position, like that Ajuga remota, we are in a position now to know the quantity, which if you pick from 10 grams of leaf, you will know that you have this particular dosage of this particular plant. And now Jathiethu is not going to give you to water to drink. I'm going to pick it, know the grams that it contains, and then I capsulate it. I make it form of a capsule. Then you take. So you find that you will get helped more than the conventional medicine, whereby they have made it so concentrated that if you take 2, you overdose yourself. So that is the dosage. That's why you find that the traditional healers, they don't deviate from what they were taught. Because from time, they know that if you take 2 leaves, it will kill all the worms in the stomach. So you don't take 10. You only take that 2 and you grind. So that's the dosage. But they are generally very, very safe. Very, very safe to take. And apart from that, if you look at somebody who is taking this traditional medicine, like I am taking, very old, but I will not get old like the person is not taking it. So it is good. It is having a lot of minerals, a lot of ions, very good constituents that is required.
Thank you. Can we take another 3? 1, 2, 3 in that order while we stand here?
Yes, yes. On the side of concentrates, in traditional healing, you find that there are some plants that you cannot just go and collect anytime. There are some plants that you will go and collect very early in the morning or very late in the evening. Why that is done is because these particular alkaloids, flavonoids, glycosides, generally they behave differently in different temperatures. And they also behave differently in different seasons of the year. When it is too rainy, you find that these particular plants will be getting a lot of water. They are vigorously growing. You find they will have enough of those particular alkaloids. Then there are some flowers that only when they are starting to bloom, not when they are fully blown, is when you pick them and use them as food. Because majorly the way the alkaloids in this particular plant behave. Apart from that, If you look at the soil content where these particular plants are growing, and that's where we are getting a problem. I want to have a botanic garden, but without knowledge. I want to use this, I want to pick a plant for in situ conservation. I want to plant it at Rongo University. But I have not done the soil testing, trying to know where this particular plant was growing, which type of soil it was growing in, which minerals was it actually depending on for it to grow to that particular size. So when I want to do in situ conservation, I have to go to the wild, pick the soil, look at the climatic condition, and then I bring that type of soil here, and then I try to grow. Because the soil is just a matter of minerals. If it is lacking calcium, I make sure that I have the right quantity of calcium. If it is phosphorus, I do that. So with the knowledge, it is easier to do a good thing other than doing a wrong thing. So in case of this particular alkaloids, it depends purely on which type of the alkaloids we are dealing with. That's why some are picked during very early morning and in the evening. And also, you realize that when you are picking these particular plants, in drying them, you don't dry them directly in the sun. You may think that this is witchcraft because you pick them and you dry them in the shade. It is scientific. Why you dry them in the shade? Because you don't expose them to highlight, which may distort the structures which you are seeing here. I showed you structures. Those particular structures, if you subject to high temperature, then you find they will distort. The molecules will be another thing altogether. So it will not be an active ingredient. So generally, you must handle them just as that layman is telling you. They are scientific in a way.
That's the power of indigenous knowledge, and that reminds us of yesterday's deliberations and resolution for our leaders that were not there. This is just adding to our resolution of yesterday, that there's a lot of indigenous knowledge that is kept somewhere which is not being used. And we resolved that we should start an Institute of African Studies, where we can study the culture, where we can study the inheritance, where we can study all these drugs that are known based on indigenous knowledge. And I think it will be a wonderful thing to do, where we have a multidisciplinary approach in indigenous knowledge base. Can we have the last three, and we make it very brief, because it's already lunchtime, we have to leave. Very, very brief. One, I can see 5 already. I don't know if we can really make the 5. I must seek permission because the brain must have moved from here to here. Another alternative is to write down the questions, and then we can privately see the presenter. Because to handle 5, it means we have to cut something ahead of us. Can we have it very, very brief? Let me request the rest to write and bring their questions so that they can be tackled very, very quickly and in summary form. Dr. Bila, you can start.
Prof, my mother could not give you a name of the plant. She would tell you, she would give you uji to take as she goes for the plant if she was treating you. So how did you convince these people to get the 35 plants? Which methodology did you use? I'm worried.
State the name of this particular plant willingly and very fast. When three, there is a consensus of three who say this is this, the other one said this is three. Maybe the rest do not know. Then we were nearly feeling that this is the name. And then we don't leave it aside. We come again another time. If they repeat the same names without any change, then we are certain this is the rightful name of this particular plant.
Next question.
Okay, mind. Thank you so much, Prof, for the yeah. This is an effort to transform tacit knowledge into explicit knowledge. Very, very much appreciable. Now, maybe you did not tell us there is the Dumurwok and the Ngueyo part, but that could be for another day. Now, are there efforts to establish botanical garden in RU, Rongo University, and what are the constraints?
That is okay.
Are the rest of the questions coming or?
No, they're over.
Okay.
You can start with it.
Yes, the first question, the second question, which the Rongo University establishment of Botanic Garden Rongo University, attempt has been made to start a Botanic Garden in Rongo University. I think I'd written a proposal and gave it to our former DVC AA, and he read it, corrected it, and he was very positive towards it, very positive. But unfortunately, he left when we had not concluded. But there is a proposal which I had written with the budget, and he was going to be a part of it, of the Botanic Garden. And I think when we make a follow-up, this is something which needs actually to be embraced by the administration who are here. I'm very happy that you are here. Really, if you look at where botanic gardens are, like in Maseno University, they have a botanic garden. It is a good revenue earner. Very, very good.
Last question, Dr. Akongo.
Thank you very much. Prof. Thank you for that very informative presentation. You talked about patenting, and I believe that's very important. And I know there is an institution that is responsible for the National Science and Innovations that is responsible for patenting. To what extent is this study or these studies that you've carried out have you collaborated with the institution for patenting? And then number two, innovations is very important, and I remember that we need to, Rongo University is a partner when it comes to creation of innovation hubs. Is your study been part of this, and what preparations can be done for innovation, such kind of innovations to be, to be mooted in Rongo University for the benefit of knowledge, transmission, and sustainability? Thank you.
Coming to patenting, we are trying to collaborate so much with IPR. That is Institute of Primate Studies, Primate Research. We are trying to do partnership with them, and I know once that particular MOU will be done, then we shall be ready to go. What I know is that sometimes, like in our case, we have got nearly 2 plants that we may want to patent, but you see, we are going slow. The fear, there is always the fear. You give somebody something, and it might be so powerful, like those particular institutes, and you find that your information and things goes very fast before even you can manage to do patent. But we are on the right path of patenting. I know soon we shall patent a product which is highly marketable. Thank you.
Let me add that from general knowledge, you cannot patent the plant, but you will patent a product out of that plant, maybe a formulation or any product that you get from the plant, but not the real plant. Thank you very much, all contributors, all participants, for your participation. We are behind schedule, and I want to hand over to the chairman to take us to the next session, which will be very brief before we go for lunch.
Oh, thank you very much, Professor Ngalo, for chairing that session, and also for the presentations and the presenters that have made the presentations. That is Dr. Adoyo and Professor Wagai. I think those presentations really gave us great eye-opening findings, which will be very beneficial to us and those who will be reading the papers that will be published from those presentations. I want to just briefly bring us to the closing ceremony of this conference. And because our time is far much spent, we are going to be very brief in our undertakings. I will invite two people who are willing to give very, very brief remarks or brief comments with regard to the conference. And if you give me an opportunity, I will make it a male and female affair for fairness. So if we have a male or a female person who would like to make very, very brief comments about the conference as we move to close, please, this is your time. You can take a minute to make very brief comments on the same. So can I see if you want to make a comment? You can just raise your hand so we welcome you or we invite you. Okay. Dr. Moso, please.
No.
Okay, all right.
Passing the mic.
Okay, thank you. Anyone to make very, very brief comments as we move to close? Okay, thank you. Professor Tenga.
I want to appreciate the organization of our conference, and I want to thank our two DVCs who have been here and availed all that they could to make this work. The only thing that I would want them and the committee to do more is that the hall should be full. There are some key people in the university that would act in my thinking it would be a compulsory to come whether you have a paper or not. And those are deans and heads of department. Because when we have, and it's international, if it is live streaming, then you can see what we are live streaming. Thank you.
Thank you very much, Professor Otenga. Any female? If we don't have any female, we can give it to another man. Okay, sorry. Do we have any? We wanted them to volunteer. Okay, fine. Do you want to? Okay, please pass it to Dr. Wagude.
I want to say that indeed this conference was a notch higher than the previous one. And on a very special way, I would wish to thank the committee under the leadership of Dr. Ambuchi. In this conference, we were able to get variety of papers, very interesting, and the last one being a case. Now, it is important that we take note of what our key speakers were able to bring on board, specifically key speaker number 1, who mentioned that in such kind of a conference, we need to have our students with us because when they come on board, we are training them on what they are expected to do. I remember the first conference that I was able to attend, I was carried to that conference with my supervisors. So as scholars, as supervisors, let us encourage our students to be on board in such kind of activities. To the management, very special appreciation. Your being here was an encouragement. God bless you, and thank you so much.
Oh, thank you very much, Dr. Wagude, for those comments. I think the Secretariat is taking note, and we will compile those particular comments together with the findings and the resolutions that the conference has been able to arrive at as we prepare our report. Allow me now to invite the chairman of the conference organizing committee, that is Dr. John Justo Ambuchi, to make his remarks, and then invite the DVC ASA to make his remarks as we move to closure. Thank you, Dr. Ambuchi.
Thank you, Chair of the session. I want to thank all the members who are present here for this closing ceremony, and I want to start by highlighting a few items. Before that, I want to acknowledge the presence of our guest, that is the DVC AFP and the DVC ASA. Welcome so much. When you come around, we appreciate a lot and we acknowledge your presence. It makes a difference. I want to start by saying that in this particular conference, the 4th International Multidisciplinary Conference of Rongo University, which started on 14th and ends today, we had 52 abstracts that were submitted for this particular conference. Out of the 52, 33 have made presentations, and that is 63% of the abstracts we received. They have made presentations virtually and physically. On that note, having made those presentations, we had 4 keynote speakers, 2 keynote speakers for day 1, and 1 keynote speaker each for day 2 and day 3. I would like to invite Dr. Maren here for just 2 minutes to sum up important points that we got from the 33 presentations from the 4 keynote speakers. I hope you are ready. Maren is not ready. She was still preparing something. So we'll skip that part for now because of time. I would like to inform all members who presented that we are giving you 2 weeks to go through your papers, adjust corrections that members gave you when you presented, and finish up with your paper, because the abstract you have submitted was a representation of the paper. So after 2 weeks, we require you to submit the full paper, and that full paper, we are going to submit the same for peer review. We are going to have it for peer review, and we shall publish it in our journal, Ijoru. So we are not just going to publish it as a conference proceedings. You know, conference proceedings are papers that I've presented even without being refined. But we want your papers to go through peer review so that it is published in one of the volumes of our journal. So I hope you have marked that, all presenters, both online and those ones who are physical. Kindly work on your papers so that we make them published, and they should count as a publication, as a manuscript, as an article after being published. I would like also to bring to your attention that we require your feedback on how the conference has been, and the secretaries are given a form with 3 questions. Kindly be honest and fill that form and submit it back so that we can get the feedback. It will help us in the future preparations. After the conference, we are going to have a visit to Tim Lich Oenga. Is it Tim or Thim? Thim Lich Oenga. We shall be led by Professor Ngalo. He will guide us on the way forward. At the same time, I think a list has been going around for you to feel if you're going or not. Kindly submit the list to the Secretariat. Let the Secretariat know how many people are going, because you are going to pay for the payment. We want to cater for it. Let us know before we leave here. This conference, we have had items that you are supposed to have. And these are, you need to have a receipt for your payments made. You are paying to the university account. I want to believe you share the messages. So you'll be given a receipt, an official receipt for the conference. If you haven't gotten, kindly liaise with the Secretariat. They should be able to give you a receipt for the same. We have the program, the program and the book of abstracts. I want to believe all of you have it. If you don't have and you deserve to get one, kindly check with the Secretariat. Branded notebook, branded pen, and branded tag. You're supposed also to have the same. If you don't have, kindly liaise with us so that you get it, because you're supposed to have. These items are supposed to be put in a branded bag. Because of some technicalities, we are not able to get the bag by now, but I want to assure you the bag is going to come, and we are going to give all of you your bags. So when we leave here, just know that I owe you a bag. A branded bag, not just a bag, a branded bag. And you'll get it. I'm assuring you you'll get it in a matter of a moment. So those items, if you lack one, just see the Secretariat. They should be able to help you to get these particular items. They are for your reference and for your use. You know, when you get out and say, I'm from a conference, somebody will ask you, what shows you are from a conference? And those items will be able to show. I want to appreciate the following members, because this conference could have not been a success without you. These are the committee members who are here. Some are not here today. Committee members, can you rise up wherever you are? Just rise up. Yeah. And the subcommittee members also? Yes. This conference has worked because of the men and the women who are standing here. There are others who are not here. I want to thank you in a very special way for the coordination and ensuring the conference succeeds. Thank you. You can have a seat. This conference could have not taken place because if the administration could have said there is no conference, it could have not happened. I don't want to say the administrators will stand, but they are represented here by the DVC, AFP, and the DVC ASA. We thank you so much for allowing us to assist us to run this particular conference. This conference could have not succeeded if we didn't have the keynote speakers, ranging from Dr. George Eshamwata, Dr. Elisha Ogada Acheng, Dr. Bed Samburu, who is our waziri here at the county, and Dr. Niasi Saliu. They have been instrumental. You can all agree that we had very powerful keynote speakers. Nobody can dispute that. Whatever we have shared from and gained from them is so much. So I want to thank them. I want to believe maybe they are online. They have seen this. We appreciate so much. I want to thank all the participants for coming to share the knowledge, the ideas, the insights into the future research. Professors, doctors, students, all of you, we acknowledge your presence and your contribution to this particular conference. I wish the whole university was here. It could have been so great. I want to thank the Secretariat. The Secretariat has really played a big role, and the ICT and the media, led by Pascal, Irene, and Roy. Can all of you stand with all the members of those particular departments who are with us? Can you rise up? Even they are in the cameras, huh? All of them. Yes, I think there are some who are not here. Thank you so much. This group has made great, because it has not gone online. people could not be following us. All this coordination here is because of these men and women who are here. So thank you so much. You can have a seat. We also had two students, Kevin and Kelvin, who really assisted us in design. You can see one is behind the camera here. They are behind the cameras also here. They have been helping. They have walked the journey with us as a journal, Ijoru. Even all the designs, it emanates from these brains. Before we take them out, they work tirelessly to ensure we have good designs. I want to also appreciate our supplier, who is Sebit Suppliers. They have done a tremendous job. I want to believe these book of abstract are of great quality. If you see the quality of these items, it's great. And based on that, we are saying we are getting even the best bags that are coming. So I want to thank them. And last but not least, I want to thank the hotel management, because if it was not for this facility, we could have not maybe succeeded well. So I want to thank them in their absentia. Ladies and gentlemen, as we come to the close of this extraordinary conference, I would like to extend my deepest appreciation to each and every one of you for your active participation, engaging discussions, and invaluable contribution throughout this conference. It has been a privilege to witness the exceptional talent and knowledge present in this room. Not only in this room, but the two rooms that we have been having our conference. Throughout the past 3 days, we delved into a vast array of topics, ranging from groundbreaking research and technological advancements to thought-provoking discussions on social, like the position of women. You know, it elicited a lot of debate. You remember that presentation by Dr. Ogueno? Yeah, such like presentations. And environmental challenges. The diversity of ideas and perspectives displayed here is actually a testament to the power of multidisciplinary collaboration and the collective pursuit of knowledge. Our keynote speakers and presenters shared their expertise, shedding light on the innovative and solutions and bold visions that will shape our future. We have explored the potential of emerging technologies, the importance of sustainable practices, and the critical need of inclusivity in all our endeavors. Ladies and gentlemen, and our chief guest for today, Professor DVC FP Professor Tarus. This conference was not just about the exchange of ideas. It was about fostering a sense of community, connecting individuals with shared interest, and forging new relationships. I encourage you all to continue these conversations, even beyond these halls that we are in. Let this conversation continue, to seek our partnerships and even to collaborate on projects that will drive us closer to our goals. Our keynote speakers even told us about how we can be able to collaborate and we can be able to pursue as a university. Remember, the challenges we face are complex, but together we are unstoppable. Each one of us plays a crucial role in shaping the world we want to live in, and it is through our collective efforts that true change is realized. I extend my gratitude to our sponsor, particularly the Kenya National Commission for UNESCO, and all the organizers and volunteers who have worked tirelessly behind the scenes to ensure the success of this conference. Their dedication and support made this event possible, and we owe them our deepest appreciation. As we depart from this event, let us carry with us the inspiration and momentum gathered here. Let us embark on our respective endeavors with renewed passion and determination, armed with the knowledge and connections we have gained. Thank you once again for joining us in the celebration of this particular progress, the innovation and the collaboration. Together, we will continue to push the boundaries of what is possible and create a better future for all of us. Safe travels as you go to your various destinations until we meet again in the next conference of 2026. God bless you. Allow me to now take this moment to invite DVC ASA Professor Michael Ntabo Mabururu, even as you think about the 2026. Thank you. Let us welcome him again with a clap of hands. Thank you, Prof.
Thank you so much, members. Thank you, the chairperson. Indeed, the chair has done his work. The committee members, of course, the VC, the colleagues who are around, and first and foremost, we thank God. So mine will be very short. I want to revisit what this man called Ambuchi said. The items promised. You know, a receipt. That one you will get. Program. That you must get. Book of abstracts. You must get if you have not gotten. A blended notebook and a biro. And above all, a bag. You know, sometimes people say, speaking is very easy and promise is political. There was no politics in the promise we made. The VC here is going to say something more about it. I've been talking with this man. I don't know, of late we talk too much with him. And you know, we were all disturbed, including the VC. You know, circumstances, some of which are beyond us, power, many things. That is what laid the bag. But you can be very sure you will get. Because if we stand, all of us here, and promise things which are not there, then we become people who cannot be dependent on in the future. So I think I wanted to affirm what he has said. You will get them, and sooner than later. And you know, maybe there is a reason you never got them when they were supposed to come. And still you will be happy to get them at the right time. They say God's time. So mine is to appreciate all the participants. I think I've seen some of you have really persevered. You know, like in any other conference you go, the first day, second day is full house. The last day, normally it's not very unique to us the way it is. But I think what Professor Tenga said, it also touched me. These things we say, wanna busy many times, and sometimes some of us don't take them like we are saying them. Whether they are said from whichever quarter, the argument still remains the same. We were very few of us, those who were to be here, to be very sincere. Know that those who are here didn't have much to do. You know, it also depends on how you look at things which have to do with the things of the university. You know, we demarket ourselves by just representation and representation. Either we are there or we are there. There are no two debates about it. So I'm asking those members who come from those departments. I know all of us are representative, more so the academic. Adoyo, you have a message to pass. And you know to whom you will pass. Must I tell you? And Umoso, you have a message to pass. But we don't think I've forgotten. And now, education, where is it? Umoso, I've left Infocom, science. Science now, Ambuchi himself. I think Ambuchi now, just want to say, we met, we agreed. Some of them were there yesterday. But you know, say, extend the argument. We were there and we were not there. Oh, nobody is supporting anybody. We are just supporting ourselves. And that's how any institution grows. We used to have this thing in Moi. Ask this man here. It was full house. Absolutely full house. And not because they were naive. No. It is our thing. Yeah, you see, if outsiders came, imagine. Luckily, we didn't have so many. You can imagine the impression. You know, they will find like, hey, these ones are organized very serious things that they call multidisciplinary and international, but the organizers themselves are not organized. So I think, Ambuchi, I got your message, not from the speakers, but you know, we published it. We said in Senate, in Deans, we said it where it was to be said, if it was to be said well. So I think members, let us now try to be like we are part of the institution. So let me not go too much into that, but I really appreciate all of us, and I appreciate management definitely for the sponsor and the UNESCO, and the hotel, and our students, and the secretariat, and above all, we appreciate God who enables us to be here without any challenges. So, you know, for me, I say many things, but I also prefer saying few. What we have learned from here can only be seen when we go back home. You know, knowledge, you know, we have shared a lot of knowledge from different disciplines. So this one should bring us together. This one should tell us how we should work together. Nobody works in isolation. And if we work together, we are going to achieve that which we are supposed to achieve as a university. And all of us will be happy. Yeah, I like quoting philosophers. We did them a long time ago, but I don't know why they stuck. There is a philosopher called Immanuel Kant, who said, and that quote is still there, it's called a categorical imperative. Do that which you do in a way that you want to be a universal law. What does it mean? Do it in a way that it is good for you and everybody can accept it. And you know, when he said that, he didn't want to explain more. He said, do it and do it well, not for yourself, that even other people can appreciate. So, Ambuchi committee, you have done it well. And those who have presented their papers, they have done well. What we have done can be accepted universally. And that is the spirit with which a solid society is built. So as we part and we go to the adventurous place, I wish you all the very best. And I know it has been hectic. And you know one thing that I find myself a bit contradictory almost of my friend. We say that people don't like, you know, if you take us out, we feel good and most of us will come. We are out. How many of us are here? Yeah, in fact, Professor Tarus was telling me now what was the need of us arranging this thing out. It's like a Rongo University business. So let us not talk. You know, it's a theory of correspondence of truth. That which we say must just correspond to what we believe and mean. This was a good outing also. Sindio. It was now a business and a serious business without any other thing boring you, Janet, that the students are disturbing you, class. Now, you know, it is also a time which we were to reinvent ourselves. Anyway, let me stop there. And I wish you all the very best. And I don't want to say much. I may want now to invite the acting VC to come and say his words of wisdom. Yeah. And I finish by saying, one who knows that he does not know is the only the one who can learn. That is Socrates.
Thank you very much. Professor Ntabo, our colleagues here, the committee that organized this conference, good afternoon. Yeah, it's another moment to come back. I know we were here on Wednesday to start off. We managed to sit through the session on Wednesday. It was very interesting. And yesterday I was following. By the way, we were together yesterday. I was online. In fact, I think I kept, sometimes the voice was not coming through. I kept asking Roy, well, what's happening? So I was actually, as I was working in the office, I was also following. Because the reason why I do that is because this is the only business we have, really. As academicians, what else can we do apart from teaching is nothing, let me tell you, colleagues. You can never be the best teacher, and we promote you until you become a professor. In fact, we normally say the worst teachers are professors. Because you know why? They find time to do research because they are chased away by students. I don't know whether you are getting what I'm saying. So they are given less workload in class because students are not, they are not interesting people to interact with students, so they find more time to research because we give you more points when you publish. Yeah, I mean, that is exactly what happens. So for me, my first business is interacting with colleagues in a forum like this. This conference is biannual, isn't it? It's after every 2 years. So when I find a room like this, and I was asking Prof. Bwana, what's happening? And exactly what he was asking. I was to say the first day, but I said maybe people are still trickling in. Yeah, but you know why I'm saying that is because you benefit a lot. If this conference we had people drawn from many countries, by the time we were living here, we would be leaving this place with contacts. Some of you would be external examiners of some university in Namibia. Some would be, you would be partnering with somebody publishing a paper elsewhere. You would be invited to be a keynote speaker somewhere. Who would have built networks here. But we have also built networks because I've seen a lot of social capital rolling around here. So the reason why we do this conference basically to get a view of what others are saying, of what we are doing. Personally, I've benefited a lot. In fact, when we had the first day, and he was called Dr. Who? Dr. Eshamwata. And very captivating revolutions he talked about. He talked about Industrial Revolution 1, dealing with mechanization, steam power. He talked about Industrial Revolution 2, that is electric power, and I think that is assembly line, the mass production. Talked about Industrial Revolution 3, which is about automation, computers, that came up to 2015, 2016. Then he talked about Industrial Revolution 4.0. And I became more concerned about 4.0 because he talked about the world has moved away from the traditional way of doing things, and we are now in another world of IoT. And what interested me more is the robotics. And he was trying to play a video, Sophia. And I was asking myself, so what will be my role in the next 5 years? Will I still be in class teaching students, and will we still be doing this, what we are doing today? The old jobs are going, and new jobs are coming. I saw somebody posting a clip of what the president was saying in my rural place, a place called Taptengele. I don't know whether you've had that clip running around. Of course it has. I don't know whether it is true, but truth be said, jobs have changed. Changed from the traditional jobs of Industrial Revolution 1, where we're doing mechanization. It has moved away from Industrial Revolution 2, where we are talking about assembly line. Moved away from computers. Now we are in AI. You can publish a paper using AI. The other day, somebody was preparing some slides for presentation in a conference, and we were taking dinner. And she told me, you know, I want to prepare a conference. I'm doing a presentation tomorrow. She's a member of a World Aquaculture Society. And she said, I wanted to do some presentation tomorrow. And she said, let me ask AI. And within 5 minutes, she had slides, 15 slides. Her business was only to correct and remove some, add some, remove some, add some. I was shocked. I'm not an AI person, I'm not an internet person, but I was shocked. And then I was asking her, so now that you have done this, how do you own this? And she tells me it doesn't matter as long as I've communicated to the audience. Precisely, that's where we are. So in the education sector we are in, that message of that presenter should really have caused us to start thinking, what is the role of a professor in the next 10 years? And I'll give you an example. In 2017-18, we were trying to come up with an ERP system where I was. And people were resisting, and people were saying, no, it's not possible. We tried open and distance learning, and people said, no, it's not possible. So we went to Baringo for a conference, not really a conference, but a workshop, a 2 days workshop. And I tried sharing with this team because we were trying to get a buy-in so that we can develop online materials. Because we had put it in performance contract and nothing was coming through for 2 years. So we decided, let's go out and share. So I decided to prepare some slides. And my focus was the future of university education. And I had read a book by one of the authors, and was talking about the future university 25 years from now. And that book was dated around 2012, 2013. So 25 years from then, you'd be talking about 2030 something. So I had a benefit of getting that book, and I used that book to explain where universities will be 25 years from now. That was around 2019. And I showed them that the biggest universities in the world today are not traditional universities. Google and see. The biggest universities with 4 million students. Indira Gandhi Open University in India, 4 million students. There's another one in Pakistan. There's another one even one in Tanzania here. Open universities have the biggest number, 4 million. I can imagine. You can imagine what would happen if Rongo was an open university with 4 million students, no buildings. You can imagine the resources we would have. And that is the future of the universities that we are talking about. What happened after 2 years from then? We had COVID. And we had no choice but to go online. After COVID, we went back to Baringo, same room. And I did the same presentation. I told them the biggest universities will be virtual universities. And they said, we have agreed, we have accepted. Now they have decided to roll. Because our profession is being disrupted. The disruption is real. And that presentation of the first presenter yesterday is something that we should take home. What will we be doing 5 years, 10 years from now? It is purely data-driven, because we will not have classrooms. We will not have. I wish our librarian was here. We will not have libraries. We will have virtual libraries. So even our librarian here will have no job. So what does it mean? He must then up his game so that he can be able to play the game of a librarian of that time, of tomorrow. So our jobs are at stake, and we should not be caught off guard. Open University is now up and running. Some of us will be hired by Open University virtually. You don't need to be there physically, virtually to run those programs. Some of the classes will be recorded classes where when the lesson, the students just clicks, the lesson is on, and there's somebody who is making a presentation, recorded lessons. So if lessons are recorded, what will be the role of a professor? So those are real questions that we need to be start asking ourselves, even as we move towards tomorrow. And you see now, the beauty of a conference like this is that it starts to make us think about where we are and where we are going. So somebody in Rongo who never turned up for this session will not understand, will think that business will be as usual. It will never be as usual. So I want to appreciate that we have been here, we have had a good time, we have had what is happening in the world, we have also had the projects that you are doing. We really appreciate. We have done what we have done. And the question that we are saying, and I'm happy that I've heard from the chairman, is that the output of this conference then would be published. Because again, information that we keep without disseminating, because as a university there are three things. We do research, we train, and we do what? We disseminate. We need then to disseminate the information that we have managed to produce. And I'm happy that the chairman says it will go into our journal. And if the journal cannot accommodate, we can also think of conference proceedings. Yeah, why not? Conference proceedings also earn points. Because I am not very sure whether also all papers would qualify in terms of quality. Because again, I am sure in our journal there are quality requirements. So if a paper doesn't meet the quality requirements, the checklists that we will have, or it's rejected by peer reviewers, where do we take them? So think about maybe we can put them into conference proceedings. And we don't need to print hard copy conference proceedings. Again, Industrial Revolution 4.0 tells us that soft copy, a PDF, well done, with the ISSN number, and that is possible, so that by the time we are coming in to the next conference, we already have an ISSN, and we are able to run conference proceedings. Remember also, as a professor or as a lecturer, you want to get promoted, we award marks. I don't know, I have not seen what the itemized scores for promotion, but I'm sure it must be there, because it's a peer-reviewed conference proceedings, which perhaps could have half the number of points, I don't know. So let's think about it in that particular light. I'm happy that we have sat here all through, and I'm very happy, by the way, because really, given the attendance that came through, some of us would have really given up, but you stuck on. But we have take-homes. We have take-homes. So what can we do so that by the time we get to 2026, what I had, we have a more focused, of course I'm not saying this is not focused, but really a more inclusive, a more diverse kind of a conference. And there are quite a number of things that we need to do. We need to ask ourselves, did we market this conference adequately? I don't know. What structures do we have within the institution? And I've heard what Professor Ogenga said about our program leaders, where we are. They are absent. How can that be allowed? If the dean, the head of department, is missing in action, what motivates us to be here? So we need to look at our structures, and because a conference like this is a very important university activity. So we need to ask those questions. What about our students? And again, I want to say thank you, Pana Otenga, for bringing your students. Because we are asking students to publish. How will they publish if they have not had a chance to come and listen on how to even prepare a PowerPoint presentation? So even as we go to the next conference, we need to ask ourselves, what is the purpose of a conference? And the purpose of a conference is capacity building. So that we can even set aside the first day of the conference and say, this is for postgraduate students, and we get people who are able to talk to the students on how to publish, where to publish, what are the research processes. A whole day, we can dedicate the first day for postgraduates. And we get facilitators internally, externally. The second day now, we come in. By the time we are coming in the second day, these students will have also seen what is required of them. So when we come in now to discuss what we have found out, now we are able to blend. When you go to these big universities, the global universities, the Ivy League, the best universities that we always talk about, they always talk about research from the time the student is admitted up to the time the student exits. And this is the opportunity for us to allow that culture of research to be embedded in our students. So we need to look at how do we bring students on board, especially in this particular conference. There are other things that we also need to look at. What are the incentives that we need to bring on board to allow people to join? And I think we'll have to discuss with the committee, what are these incentives? How is our pricing model? Could it be that the pricing model is what makes this happen? Can we get some financials? Because the more financials we get, and I'm happy you got UNESCO. If you got 2-3 other UNESCOs, perhaps maybe the amount that would have been charged per person would have come down, and perhaps also maybe you could have, you get what I'm saying? Because a conference is not a university activity. It is a community activity. It is a stakeholder activity. So we have banks that also serve the university. And we can talk to them. Some of them could have sponsored bags, for example. Some of them could have sponsored the stationery. Because these are our stakeholders. And we pay them a lot to offer, we give them a lot of money. So, and we stand at a point where we can tell them, now we organize a conference and we are partnering together. What are you giving us? And we can stand at that and we demand, because we are giving them millions of money, really. So when we are also doing our business, they should also come in. So maybe when we come to the next level, we need to get this so that we can be able to reduce, the costs on the students and the faculty. Then we need to also say, we have also projects in the university that are funded by grantors. We have many projects. We have so many projects. Can we also tell these projects to chip in something? Because they keep organizing conferences, meetings in some places. Now that we have a serious business like this, can we also tell them that we need some contribution into this particular conference so that we bring all our resources into this? I'm telling you, if we do that, you will see a very serious conference that can attract people across the globe. Then we have also stakeholders. We do research with other people. The other day in fact, I think it was yesterday, I was confronting somebody in my office, that you have a team, that you have a project that you are writing. And I'm not seeing any of that university presenting a paper. What happened? You didn't invite. You see? But if that person didn't even come himself, then how can you even invite? You get the point? Yeah. So we have to be proud of what we do as Rongo. And I'm using the same words that gentleman from Egatodi said. And the moment somebody comes to tell you, you must be proud of yourself, it's something very serious. I felt like hiding myself, by the way, yesterday. I felt so bad. The guy told us, we must be proud of Rongo. And I'm asking myself, what? And it is true, of course, I had the same feeling. This is a lesson to take home. We need to build a Rongo that we are proud of. When we are organizing a conference, we should not be saying, you're in a conference here, Ambuchi and the team. How can it be a conference of Ambuchi and the team? And the university has injected sufficient resources into this process. For the last 3 days, I've not had time. This guy has been calling me even at night. In fact, this is one of the times that I've been most stressed. He called me. I mean, he's been calling me. He's been walking into my office. I think for the last 1 week, you've been in my office more times than I have ever seen you. Just because of this conference. And then there's somebody saying, you're Nekasi Ambuchi. Seriously? And I'm not sleeping? I hope you are getting what I'm saying. We need to prioritize what we need to do at Rongo. What makes Rongo University is research, is dissemination, is training of students, nothing else. That will give us good ranking. It will give us good name out there. It will give us students out there, especially when we come to student enrollment. There are many other things I would have wanted to say, but I want to say I'm happy that we are here. I want to say maybe, and I know Dr. Odero. Dr. Odero has been going out, especially with this issue of innovations with Kenya. Kenya is also a stakeholder. We also do we have a project that we are funded by Kenya to do some project. And I know there's a team that's already going to Naivasha. I don't know whether you are among there's a team going to Naivasha. I think that must be the Dean School of Arts and I think Steve Olo and another. How can we bring them on board? Can we also set up aside some table for exhibitions so that we are not just here, we are also exhibiting what Professor Wagai was talking about. You know, because we've talked about medicine here, traditional medicine. Where is the table? Where is the table to say, this is for Nango? This is for Kwato. You know those, because you train at the same time also you know when you display, the seeing is believing. So we need to, maybe going forward, we need to set up a table and we will set up a room like this where people would be coming. Rongo, we have a textile. We should be selling those things around here. Where? I didn't even see anything. Rongo here. I know Prof here has a honey. He should have collected money here. You get what I'm saying? Those are the things I'm saying. Apart from coming here to do the presentation of papers, we could also set up a display of our innovations. Bring even undergraduate students who have innovations. That's how we can bring a lot of vibrancy in what we do. I don't want to say much. Allow me to stop there. And I want to thank the committee. I really appreciate your contribution. In fact, if there's something that I have seen out of this committee is commitment. If this committee was not committed, this conference was not going anywhere. It's like I saw as if it was actually a project of the committee, but you've done it well. I really want to appreciate. I want to appreciate the paper presenters. It was wonderful. Next time, let us invite people across. You know, this, like, for example, even Tomboya here. Tomboya here, we should have at least two people from Tomboya. Kisii here. We had one. Kisii. We didn't have Kisii, but they normally come when they are normally our external examiners, they are our part-time lecturers. When we have a serious business like this, they are not here with us. You get what I'm saying? So, one from Kisii, but Kisii is big, we need 10. Colleagues, thank you very much. I want to say I'm pleased and allow me to declare this conference officially closed. But before that, there are certificates that we want to give out for people who are here. I don't know whether you have, I know there are people who have done so well in conference presentations who would be also awarding the best conference presenter, would also be awarding the best paper of the conference. You get the point, eh? Because when you go out for some promotions or you're looking for a job somewhere, those things make a difference. So maybe in the next level, we'll look at the best paper presented, the best presenter, the best paper, 1, 2, 3, and it can go with some. Yeah, why not? Because we'll have collected money from our service, our stakeholders. Yeah, I mean, we'll have collected something here, something there. It is the only opportunity for us to award our own, especially with regard to, you know, but I don't know. I know some of you are your researchers. Eh? It is very difficult to produce a paper. It takes a year. That's why some of us we cannot get promoted because you hardly get a paper. When a student gets a paper, it is not in Scopus index. It's thrown out. It doesn't help you. So, colleagues, we are moving to the next level of presentation of certificates. And allow me to, I want to give this opportunity to Dr. Odero to take us through.
Thank you very much, colleagues. Let's appreciate Professor Tarus. I was confusing Tarus and Tunai. Professor Tarus for full comments. We'll do a 3 factorial, right? Let's go. Thank you. So I will call the names, and then if you hear your name, you will come, and then Professor Tarus will hand over the certificate to you. Boke Joyce Wambura. Oh, she presented online, so I think, okay, thank you. Ochieng John Kevin. Online, thank you. The chair can keep that. Ngalo, Z Ngalo Otieno Ayayo. Move that side. Thank you. Lillian Awur Pande. She was here? Please take. Thank you. Okay. Yes, if you have an association you can take on behalf of someone. Thank you very much. Thank you. Thank you, Damaris Gechemba Nyakoe. She's not in today. Sang Irene Chepkosgei. Sang Irene. Then Josephine Amundi Anyonga. You can come in that order. Followed by Gidnora Mkacharo Mwashembe. Thank you. Thank you very much. Josephine Amundi. Thank you. Gidnora. She's there. Thank you. Kelvin Mwaniki. Kelvin. Albert Ouma. Okay. Albert Ouma. Kelvin Okoth Otieno. Gladys Chebet Kongoei. Gladys Chebet. Josephat Ogweno Okech. Thank you, Gladys. Josephat Ogweno Okech, followed by Jacob Omondi Orage. Jacob Omondi Orage. Jacob, followed by Millicent Awino Ochola. Thank you. Thank you very much. Eric Juma Kashara. Eric Juma Kashara. Okay. Rose Achieng Agalo. Eric Juma is there. Rose Achieng Agalo. Followed by Maren Atieno Akongo. Thank you. Congratulations, Maren Atieno Akongo. Wanjala Victor Wafula. Chamwada Cynthia. Chamwada Charles Okeo Wagunda. Charles Okeo Wagunda. Thank you very much. Charles Okeo, you can also pick for Dr. Wagunda. Stella Migide Madete. Stella Migide Madete. Or Sadati Okeo. Sadati Okeo, followed by Evans Ochieng Ouma. Okay, Ouma was here. Johannes Adongo Makodia. Johannes is there. Followed by Janet Auma Wagude. Thank you. Janet Auma Wagude. Joel Nakitare. Followed by Bunde. Joel Nakitare? Yes, please. Joel Nakitare. Followed by Bunde Leonard William. Thank you. Bunde. Charles Kesero Tunai. Charles Kesero Tunai. I think Tunai was here yesterday. Frederick Ogenga. Roy Obiero. He's not here, but he was here. Roy Obiero Awiti. Abila. James Onyango. Abila James. Edward Odhiambo Anino. Edward Odhiambo Anino. Dr. Anino was here. Yes. Samuel Otieno Wagai. Followed by John Kipngetich Korir. John Korir. Millicent Awur Otieno. Elisha Omoso. Ann Costa Mugalavai. So Elisha Omoso. Thank you. Thank you so much. Ann Costa Mugalavai. Moses Otieno Ngaro. Moses Otieno Ngaro. Okay. Moses Otieno. Anthony Oworo Okeyo. Okay.
That's my student.
Okay. Thank you. Thank you very much, Prof. Ouko Calvins Ooko. Eliud Oyo. Wilson AP Otenga. Thank you, Prof. Thank you. Eric Omondi Odero.
Eric Omondi Odero.
And then finally, John Justo Ambuchi. Maureen Adoyo. Wachachu. Okay. Thank you. Okay. Oh, thank you very much, ladies and gentlemen. Can you?
You can just present In the meantime, as we are waiting for the final certificates that are on the way, I would like to introduce one of our guests and tour guide. He's called Kelvin Saitoti. Please stand up. Kelvin Saitoti is the curator of Thimlich Ohinga. We are privileged to have him here, and he's going to take us through the tour of Thimlich after this.
Okay, we have two more certificates to give. We have two more certificates to give by the chairman, and this for our chief guests who also attended the conference. Yes, so we have our DVCs, Professor Michael Ntabo Mabururu. A round of applause, ladies and gentlemen. Thank you. And finally, Professor Daniel Tarus. A round of applause, ladies and gentlemen. Thank you. Thank you very much. Oh, thank you very much, ladies and gentlemen. We have come to the end of our conference. Our chief guest had already pronounced himself and declared the conference officially closed. Okay, so we move to have our final prayer. If there is anyone who did not get a certificate, probably because an omission, we are going to organize for the same with the Secretariat. Please forgive us over that. We are going to organize that with the Secretariat just immediately. Okay.
Sorry, I think it's important we give one certificate that was omitted. They forgot to give, so we have to give it because the owner is here. Because it's good to give. So, Pascal Ekesa, welcome for the certificate, and we'll invite our guest, the VC, kindly.
So, Pascal Ekesa, thank you. Thank you very much. Thank you. Yeah. Thank you very much. So finally, I want to thank you. Together, I know we are going to move with speed now after this so that we can catch up with time. We are now going to play catch up because we are basically running slightly behind schedule. So allow me to invite Dr. Adoyo. We will be upstanding as we take the national anthem, and then Dr. Adoyo will give a closing prayer. Please move forward. Dr. Adoyo will give a closing prayer, and we'll also pray for our lunch. From here, we move straight to have our lunch, and then we go to Thimlich Ohinga.
We'll sing one stanza.
Only stanza 1 of the national anthem in English. Who can pitch it?
O God of all creation, bless this our land and nation. Justice be our shield and defender. May we dwell in unity, peace and liberty. Plenty be found within our borders.
Let's bow down for a word of prayer. Heavenly Father, this afternoon we want to come before Thee. We want to thank You for the guidance You have given us from day one until the end of this meeting. Lord, as we disembark from this venue, we pray for journey mercies. And as we go for lunch, we ask You to bless what we are going to partake. And all blessings and honor returns to You, Lord. For in Jesus' name, I do pray this short prayer, trusting and believing. Amen.